Hello, everyone. Welcome back. So we'll just head on to the next session of this aortic dissection talk. Let's start with the questions. Lakshay, what other differentials you would think of when you're thinking of dissection? The big differentials that you should always think of.
I think the really important ones are pulmonary embolism, ACS, like with every chest pain, and the other one that we think kind of clubbed together is pericarditis and tamponade. Now, besides these, we should always think of pneumonia, Bohr-Haave syndrome, and pneumothorax, like with every chest pain. But if you ask three important differentials, it can be often difficult to, tease out which one is causing the problem just with the history. It'll be pulmonary embolism and ACS and pericarditis tamponade.
Yeah, okay, fine. So just gonna think of a hypothetical scenario. So in a patient of stroke or a suspected ACS, when would you scan their aorta before initiating any further treatment? Have you come across a situation where you kind of think maybe it's possibly ACS, but you're a bit worried about dissection as well?
I think just with the nature of the history, if somebody ACS, somebody's got ACS, they generally settle with morphine, not always, but most of the times they settle with morphine, a bit of GTN. Somebody got really bad chest, looks really uncomfortable. People with ACS, they generally don't look very, very, very uncomfortable, right? They often get better with GTN, morphine. They have some ECG changes. Now, dissection can also have ECG changes, but just with the history, the nature of their pain. If they say this is ripping, tearing, or the worst pain of their life, and the ECG is not STEMI, not really diagnostic, Troponin is not over the roof, just a little bit high, you should think about dissection. Same with strokes. Now, I think a couple of weeks back, I was taking care of a patient during a night shift. She had a stroke, but didn't look very comfortable. She was also complaining of some chest pain. We got the CT done, thinking, oh, maybe this is aortic dissection causing extension into carotids and cerebral vessels causing a stroke. It's totally reasonable. And because the management there differs, sometimes carotid or vertebral artery dissections do get thrombolized, but it's good to know that there is a dissection that you're thrombolizing so that you can discuss the risk benefit with the patient, because it's difficult to study this area, and it's almost always based on case reports, not big RCTs. What should be done for thrombolizing dissections, or what's actually the most effective management for these conditions?
You mean to say thrombolizing carotid dissections?
Any dissection, thrombolizing carotid dissection or vertebral dissections. They do get thrombolized sometimes, but it's good to know. If you have a story which suggests dissection with a monoplegia or hemiplegia, totally reasonable to scan their aortas with the neck vessels, carotid vertebral vessels, with the head. And often a cerebral angiogram as well.
Right. So heading into the diagnostics, is there any blood test that can kind of help you rule in or rule out dissection? I know CT is the most definitive way of diagnosing a dissection, but are there any other imaging like a X-ray or ultrasound that can help you diagnose a dissection?
And as you said, CT, if you have high enough suspicion, straight to CT. Blood tests, pretty useless. They don't add much value. They're often done to look for other conditions like coexisting ACS or ACS when your history is not getting you anywhere, or pulmonary embolism. The most studied or most talked about biomarker for dissection is now D-dimer. Some people over rely on that. Some authors do suggest that we can rule out low-risk dissections. The problem is we don't really know what is low-risk dissection. There is no validated decision rule for dissection. There are some, but none of them are externally validated, like we have wells for pulmonary embolism. D-dimer is only good enough for low-risk pulmonary embolisms based on their wells or revised Geneva score. For dissection, we don't have such a decision rule. So we don't know what is low risk. What might be low risk for me, you might say that is high risk, and I would just do a CT. And D-dimer can often be false negative in trivial small dissections, young people, if they've got a thrombosed false lumen, or if they've got an intramural hematoma. And just to go back again, the management of penetrating atherosclerotic ulcer, intramural hematoma, and acute aortic dissection, which is all called as acute aortic syndrome, the management is pretty much same. So you cannot use D-dimer to rule out dissection. You would not be able to justify if there is a mishap in this scenario. I did D-dimer and that was negative, so I ruled it out. And there is not enough data at this point. The data is looking good, promising, but we are not ready for D-dimer yet to rule out dissections. So we shouldn't use it unless you suspect use D-dimer, but not for dissections. There are other tests like CRPs and matrix metalloproteinases, some other enzymes which people have studied, but they're not good enough. So D-dimer, again, not ready yet. The other thing is troponin. Can be significantly, can be slightly elevated. Troponin has become very, very non-specific. Some people call it, this is the D-dimer of 21st century, troponin. And there are numerous reasons. I'm talking about highly sensitive troponin. If you take a run around your hospital, you come back, we do your troponin, it'll be a little bit elevated. It can go up in what people call as type 2 MI, sepsis, stroke, subarach. It can definitely go up in dissection. So you need to correlate, always correlate troponin with history. It's a good test. I think troponin is overused now, and we often admit far too many patients with just a little bit of elevated troponin. Because once it is sent, it is up, we need to find out why this is up, or we need to do 2 or 3 times to make sure it is not going further, increasing further. But for dissection, we don't have much utility of troponin.
Okay, so the bottom line is, I think, is the same. Have you heard about the Think Aorta campaign? So I think if you're suspecting that there is a dissection, get a CT. That's the bottom line.
And again, X-ray. You might hear this argument from most radiologists are on board with this, but if somebody is sick enough, CT straight away. X-ray, again, 10% of them will have a normal X-ray, 10 to 12% of them. Multiple X-ray findings are described, have been described for this, but 2 big ones would be dilated mediastinum, or another one would be the obliteration of the aortic knob. You see the aortic knob on the left side of the chest wall, that becomes blurred, or that doesn't look that prominent. It gets a bit blurry, again, because of the dissection or the hematoma. So these are the 2 big ones. But again, people can have normal X-ray in the presence of dissection, again, depending on where the dissection is. It's a disease of abdomen, chest, any back pain, chest pain, abdomen, sudden onset tearing, worrying history, you should think about dissection, not only with chest pain, but any pain. So X-rays, again, you cannot rule out if you have high enough suspicion. CT is the answer.
Okay, so X-ray findings, if there are X-ray findings which is suggestive, then that makes it more probable, but the absence of it does not rule out a dissection.
Absolutely. And again, I wouldn't wait. If you get this argument from radiology, have you done the X-ray like we often get for PE? I think this is just to remind them, this is a disease where if we delay the diagnosis, there is a 1 to 2% increase in mortality every hour. So if somebody looks unwell, they are in resuscitation room, get IVs, 2 IV accesses for them, cross-match, get them to CT, and get that out of the picture, first of all. Now, some places, now you need to discuss this with radiology beforehand. If the history is not very suggestive, or somebody is looking quite unwell, you think could be dissection, could be ACS, could be PE. Some places do that, what they call is triple rule out CT scan. So they scan their coronary arteries, coronary CT angiogram, CT pulmonary angiogram, and CT aorta all together. Now, this gives them lots of radiation, lots of contrast. But again, if the stakes are high, if somebody looks unwell, you need to get this done. And this is important to discuss. It is important to discuss with radiology beforehand, not at 2 o'clock. No, I need triple rule out CT. So you need to have this discussion beforehand. What is their kind of feeling about doing triple rule out CT scans, but at least get their CT aorta.
True. And that also depends on the local guidelines, and it's not a scan that's commonly done in many places.
Absolutely. Yeah.
Okay, fine. And just before we head on to the treatment and what are the options if somebody is diagnosed with dissection, just a quick chat about, I think we come across this a lot in the emergency department. If they need to get a scan of their aorta, do we have to wait for the creatinine?
The answer is no. if you have high enough suspicion.
Yeah.
So I think contrast-induced nephropathy, most people are on board with this now. This is no association. There are multiple other reasons because of which creatinine goes up in these critically ill patients.
Yeah.
Sometimes you get this argument from radiology again. So again, just remind them this is a high-risk condition. They can have elevated creatinine anyways if they are hypovolemic, if they have got a bit of blood loss, kind of contained hematoma, or if it's going into your renal vessels, it will be elevated anyways. You would still do the scan because this is a high-risk condition, a high suspicion. So yes, you don't need to wait. Just get the scan done. Also, I think I should also touch on the other ultrasound. I think you mentioned about the ultrasound, transesophageal echo, transthoracic echo. If somebody's quite unwell and they're hypotensing and you are suspecting dissection, it's a bit controversial whether you should start norepinephrine or vasopressors for them, because that will increase the inotropy and that might make the dissection worse. But you also need to have sort of a low normal blood pressure to make sure they are perfusing their brain. Transthoracic echo is something that we can do. Again, cannot rule out dissection. Transesophageal echo, which needs sedation, more expertise, difficult to organize in acute emergent setting, is better to pick up dissection. It's almost as good as the CT scan in critically unwell patient. Transthoracic, sometimes you can see the flaps, sometimes you can see the aortic regurg if you're skilled at echo. But if somebody's hypotensing, the first thing that you need to do is get the ultrasound, look at their pericardium. If there is a pericardial tamponade, yes. It's again controversial whether you need to aspirate or take that out or not, because I think it's far too late. You need to get surgeons on board with this. So in terms of the utility of testing, the best one is CT aorta, easily available. The next one is if you have discussion with cardiothoracics beforehand or cardiology beforehand about a transesophageal echo in critically ill, unwell patient, not suitable to get him to CT scanner. Yes, this can be done. The next one would be transthoracic echo, which is sort of poor man's transesophageal echo, not really good, but sometimes I think you mentioned about a case to me once you saw a flap in a patient. I've seen it once, but that was more of a chronic dissection. And you can get suprasternal views as well, but that needs more skill and expertise, which is difficult, often not available in the emergency department. The last one would be MRI scan. Again, takes time, difficult to organize in acute setting, often used for post-operative or kind of chronic, this thing called chronic dissection. Some people kind of develop a false lumen and they live with dissection for years and years. So post-op dissections and chronic dissections often get followed up with the MRI scan.
Okay, fine. So maybe imagine we have a patient, you've done a CT scan, you've diagnosed a dissection. What is the next step? What is the next option?
If I have a high enough suspicion, unwell patient, it's totally reasonable to start the treatment before you diagnose that. As in get to IV access for them. Arterial line, not really before you can probably wait for the arterial line before confirming diagnosis, but to IV access for these patients. They're unwell, cross-match, routine set of bloods, ECG. And if you've confirmed it, or if you have suspicion, even before confirming it, I think the two things are pain relief and controlling the blood pressure. Once you confirm it, the first thing radiologists, they generally call you back with this, if they find this on the scan, and the first thing I'm going to do even before the patient is wheeled back is call cardiothoracics and vascular surgery. And we'll go into it, which one goes to which specialty. And give them pain relief, which will be opioids, fentanyl or morphine, and probably fentanyl 50 to 100 mics to start with, and then control their blood pressure. The target heart rate, what most people accept is, it can be a bit different for cardiothoracics, what they want. Heart rate of 60 systolic, a heart rate of 60 beats per minute and a systolic blood pressure of about 100 to 120. That decreases. Beta blockers would be the drug of choice for these patients because that will decrease the inotropy, that will decrease the force of contraction, that will bring the heart rate down. If you decrease the inotropy, you will also decrease the force that comes along with each heartbeat, and that will theoretically at least prevent the progression of dissections. That's the most important thing: acute management, quick management with beta blockers, and often they need another drug. Generally, I would start with labetalol. I would probably avoid GTN as first line in this subgroup of patients, because GTN is a vasodilator. And whenever you dilate, it's predominantly, we know dilator in low dose as an arteriodilator in high dose, and talking about GTN. And that causes what we call as reflex tachycardia.
Yeah.
As in, when you stand up, you dilate your blood vessels to increase the blood pressure. Body will increase the heart rate to maintain the same blood pressure. And increasing heart rate in these patients is not good. That will again make things worse, kind of lead to progression of dissection. So GTN, if you want to use, it will be second line. Most places would use labetalol first or esmolol. And if there's contraindication to beta blocker, you go to calcium channel blockers. But pain relief and blood pressure reduction with definitely beta blockers or calcium channel blockers are the first line.
Okay.
And then speaking to the cardiothoracics and vascular.
Yeah, okay. Fine. So just moving ahead, I think we've covered almost everything with regard to the dissection itself. But despite knowing so much, we know very little about dissection, and people present with varied symptoms. And it's inevitable that we probably will miss some patient with a weird presentation.
Absolutely. Yeah.
So what do you think should be our aim when documenting a patient with chest pain, so that you are able to justify yourself sending someone home who may have a dissection?
First thing is dissection can.
In other words, what are the pitfalls of documentation?
Documentation. Okay. So dissection can happen in young people and old people. So generally, it's an age group of 40 to 70 years. But if a 28-year-old Marfan's gives me a good story, or with any chest pain Marfans, I would probably scan them. In terms of documentation, I would document the pertinent negative findings. If I'm sending somebody home with a kind of low, moderate suspicion, some things suggestive dissection, but they look really well walking around. I've watched them for a few hours. They are pain-free now. That's the key thing. They should be pain-free now, although they can have intermittent dissection. But if they're pain-free now, I've watched them for a good 4-6 hours, maybe longer, negative chest X-ray, the vitals are okay, normal ECG, I'll rule out troponin, I will rule out ACS with troponin, and maybe 1 or 2 troponins, make sure 1 or 2 ECGs are normal, and check blood pressures. Again, they can have difference. I would not just scan them just because they have a difference. They look well, everything else is negative, X-ray, troponins, period of observation. They don't require, bucket loads of morphine or other opioids or pain relief. Sensible, kind of no risk factors, no pulse deficits, big one, no murmur, I'll mention that, no big vague neurological features. I will have a discussion with the patient. I'll tell them this is what I think. It's unlikely. If I were you, I'd probably not get scanned. What do you think? I think we should probably wait. And most people they understand the risk of radiation now. And with a very strong worsening statement, I might send them home. Again, you need to tell them this is a high-risk condition. It's a thin line. We don't want to scan too many people. There's risk of radiation, problems with radiation, and we don't want to miss this. I think in your case, this is unlikely. This is the reason. This. I think this is why this is unlikely. I think you should go home, see how it goes. You're asymptomatic now. If the pain comes back, if you go outside the emergency room, you get this pain again, sitting in your car in the parking, just come back. And we will see what we need to do. But don't hesitate. Don't think your blood tests are negative. Blood tests are all, this is just a snapshot. X-ray is a snapshot. Things change. Disease processes evolve with time, whether it's ACS or dissection. Come back if you have the slightest of concern.
Okay, fine. So to kind of put it all together, mention all the negative findings in the symptoms as well as in the examination. And if you do some tests, mention those tests as well. And probably mention the discussion with the patient.
Absolutely,
And explicitly mention that you've thought about dissection, and these are all the reasons because of which I think the suspicion is extremely low. That's the reason we are not doing the scan, rather than not mentioning dissection anywhere at all. Is that correct?
Totally. What people call as the medical decision-making segment in your note. So I would just write a good note, a small couple of paragraphs mentioning discussion with the patient. We have had this chat. He's sensible. He agrees with that. He
Yeah.
knows when to come back. He's happy with that.
Yeah,
Yeah,
perfect.
I think that should be fair enough.
Okay, so I think we've almost come to the end of the discussion. So before we finish, is there anything that you can tell the patients to prevent dissection? Not prevent dissection directly, or maybe just prevent the risk factors, like primordial prevention?
Yes, there are ways you can do that. I'm just going to come to this. I'm going to briefly mention about which dissection goes where, because that's a bit of a thing as well. Type A dissections, generally your arch of aorta, and type B is your abdominal or thoracic aorta, descending aorta. Generally, the rule of thumb is type A are managed surgically, with cardiothoracics. Type B are managed medically. There are two types of type B dissections, or descending aortic dissections, which can be complicated, uncomplicated. We call complicated. The ones that we call complicated are often managed surgically. So I would, in fact, speak to cardiothoracics with every dissection. When you say complicated, that means you are not able to control pain, or dissection is progressing, or there's end organ failure, renal failure, bowel ischemia with dissection, or the blood pressure is over the roof, you're not able to control that. Then yes, complicated type B dissections are often managed surgically. So it's just get in touch with both the teams and see what they want. In terms of coming to a question about preventing dissection, I think it's just about general the lifestyle medicine stuff. Cut down smoking, cut down alcohol. So I should say probably stop smoking. Stop smoking, and I would say stop alcohol, or cut down if you can't stop. Control your blood pressure, which these things will help to eventually control blood pressure. Diet, exercises, the usual stuff. And if you have a connective tissue disease, there are guidelines to, get your aorta scanned, surveillance, and with Marfan's. Thing that I did mention in terms of this factor is, I think, vasculitis, Takayasu, or giant cell arteritis. They can also cause discrepancy in the blood pressure, so they are also at high risk of dissection. So you need follow-up surveillance if you have these conditions. If you have family history of sudden death, that can be caused by dissection. Family history of dissection is a risk factor for dissection. So get in touch with your physicians and see what is the guidance. Even for Turner syndrome, Marfan standards, there are guidelines to see how often they need follow-up. Otherwise, again, stay away from drugs and cocaine, MDMA. These are pretty nasty drugs and kind of screw up your aorta.
Okay. I think we have covered most of the things. So I think we'll stop here. So if you have any questions, please pop down in the comments box and we'll be happy to answer. Thank you.
Sounds good. Thank you. Bye-bye.